Friends, I can see that there are 3 of you already watching. You're the early birds right off the top. And don't walk away just because it's quiet. I'm just letting you all get settled in before we start. We're a few minutes early right now, preparing for our live broadcast, Surgical Safety and Sleep Apnea, the World of Anesthesiology. Oh, this is going to be a fantastic conversation. So as you settle in to watch our broadcast this evening, go ahead and introduce yourself. And Brenda, of course, leads the way. Brenda, I love that when you watch our broadcast, you always introduce yourself. So there's Brenda Jungworth. She says, hello from Edmonton. It's always great to have you with us. And she says, excited to be here. Brenda, we're excited to have you. This, like I said, is going to be an excellent conversation. I can't wait. I'm really looking forward to it. And just as Brenda did, if you're logging in, and I can see a number of you already, go ahead and introduce yourself. Our doctors and our experts that are joining us today know so many of you that are watching the broadcast, and it just brings the conversation a little closer together when you can introduce yourself and where you're watching from. We have had people all over the world watch our previous broadcasts, so we love to know who you are and where you're joining us from. And all you need to do is go into the chat box and type your comment in there, and I will bring it into the conversation. And while I'm talking about that, that's how the majority of the conversation will work throughout this next hour. Is as you write your comments, I can take them directly to our experts that are talking and bring them into the conversation. So what a wonderful opportunity for all of you who are watching. We have Zach Davidson says, hello from Annapolis. This is Dr. Karen using my son's account. I'm going to assume, I can see Dr. Height smiling in the virtual green room. So I think that she must know who Dr. Karen is. So hello to you, Dr. Karen, and welcome. Thank you for saying hi. And for the rest of you joining us, please go ahead, say hello, and let us know your name, where you're joining us from as you settle in to watch this broadcast, Surgical Safety and Sleep Apnea, the World of Anesthesiologists. And we've got one of the leading experts, anesthesiologists, joining us this hour. I can't wait to hear from him and everything that he brings to the table in this conversation. So I see there's a number of you already joined in. I would like to know where you're watching from and what your name is. So please go ahead and do introduce yourself. I want to say Happy New Year. But I'm wondering, is it too late to say Happy New Year? Like, at what point do we stop saying Happy New Year? After the second week in January, or maybe halfway through? Is it too late? It doesn't matter. I already said it. So to all of you watching, Happy New Year. I hope this new year, this 2022 year, brings you happiness and health. You know, we're all dealing with this new variant, and I'm going to ask Dr. Sam DeMaria about it. He is an anesthesiologist and many, many other titles at Mount Sinai in New York. What it's like. He's going to paint a picture of what he's going through right now. So to all of you joining us, and we have Maureen Iverson from Spiritwood, Saskatchewan. Hello to you, Maureen. I hope that your weather is mild where you are. Spiritwood, I think that is that south or north of Regina? Trying to get my geography straight on that. But thank you so much for joining us. Okay, in the interest of time, everybody, I think that we should get our broadcast underway because we have a lot of information to cover today. And tonight is going to be a very powerful conversation because we are talking about sleep apnea in connection with surgery and general anesthetic. So how does undiagnosed sleep apnea affect safety under anesthetic? And how does sleep apnea affect a patient's ability to have surgery sooner and less expensive in an outpatient clinic. These are just some of the issues we are going to explore over the next hour of this live broadcast when we are joined by New York City transplant anesthesiologist and researcher, Dr. Sam DeMaria, also the Vice Chair for Research in the Department of Anesthesiology, Perioperative and Pain Medicine. He will be joining Dr. Tamari Height, who is the driving force behind these broadcasts and so determined and passionate about fostering more collaboration between doctors and dentists and diagnosing sleep apnea and ultimately in saving lives. Dr. Height has spent the last 25 years working in general and craniofacial dentistry and lecturing worldwide for the past 10 years to dentists, to orthodontists, and medical doctors on her published research and her findings. And she's also preparing for a big summit and trip to Rome, Italy in the next couple of months, which he's going to talk about and share some of those details. I'm excited to hear that. So to all of you who are joining us from around the globe, welcome. We appreciate the time that you are taking out of your busy lives to participate in this conversation. And I want to stress, as I mentioned right off the top, if you have questions, go ahead and write them in the chat box, and then I will bring them into the conversation that I'm having with our experts today. It really is a very special opportunity to be able to spend time with people such as Dr. DeMaria and Dr. Height, who are experts in their area of medicine, and to have access to them in this capacity. So don't be shy, ask the questions. I will bring them in as I'm interviewing the two of them. It's just such a great opportunity. If anything that they're talking about tweaks a question in your head, I would appreciate that participation. So I will bring those questions in real time. Hard to believe, but this is, for those of you following along, this is our 12th live broadcast that we were bringing you in our series called The Science of Sleep Apnea. All of the conversations that we have had to date have been so insightful. Discussions that have brought together so many experts from right across North America, like seriously some of the world's best in their medical and in their dental fields. Dr. Height and I also traveled to the Breathing Wellness Conference in Las Vegas back in October, and we were really humbled by the feedback we received from countless people who are actively watching, following, and participating in these conversations. If you are interested in watching any of the 12 broadcasts, this is our 12th, the 11 previous broadcasts, all you have to do is go to the website, thescienceofsleepapnea.com. And all of our previous broadcasts exist on that website. There it is on the screen, thescienceofsleepapnea.com. You can watch all of them as many times as you want, and they are filled with great information. And perhaps if it's something you can't use, send it off to some of your friends, because you never know what kind of impact it may have on their life if, of course, they are suffering from sleep apnea. So far in this series, I love reading this out and sharing this with you. We have interviewed to date through our live broadcasts a cardiologist, a neurologist, a sleep specialist for both adults and pediatrics, a medical doctor, an otolaryngology head and neck surgeon, a specialist in telemedicine, an OBGYN, and now we're bringing in an anesthesiologist to this conversation. So an incredible list of experts that are sharing their expertise in this area. Certainly an impressive list that has been brought together by Dr. Tamari Height, who, as I mentioned, is so passionate about bringing together all specialties of dentist and medicine so that doctors and dentists can work together. And again, if you want to watch any of the broadcasts we've done to date, www.thescienceofsleepapnea.com is where they all live. My name is Carrie Dahl, friends. I'm a longtime television medical reporter, 6 o'clock news anchor, turned public speaking coach and podcast host, and I'm honored to serve as your host tonight for our virtual discussion. The format for the next 60 minutes will look like this. I will begin by interviewing Mount Sinai anesthesiologist, Dr. Sam DeMaria, who will talk about the impact that undiagnosed and diagnosed sleep apnea has in his area of expertise. And then Edmonton dentist, Dr. Tamari Height, who has successfully reversed sleep apnea and countless patients, will be joining us to talk about her work and the impact that it's having on saving lives. She's also going to provide some perspective on why it's so important for dentists and anesthesiologists and really medical experts from all walk of life to work together in this capacity. And then going to bring Dr. Height in to join Dr. DeMaria to further this conversation. A lot to cover tonight, but research and work in this area is changing lives. And more importantly, it's building the necessary bridges between medicine and dentistry. As I mentioned, once again, we welcome your questions throughout this next hour, and we will be wrapping up at 6 o'clock Mountain Standard Time. And again, if you have to leave or you're not able to watch the whole broadcast tonight, just visit the website that I told you, thescienceofsleepapnea.com. So with that, let's dig in, shall we, by welcoming New York City transplant anesthesiologist and researcher, Dr. Sam DeMaria. Dr. DeMaria is the vice chair for research in the Department of Anesthesiology, Perioperative and Pain Medicine. He holds the dual appointment of professor in his home department, as well as the Department of Otolaryngology. Dr. DeMaria did his residency at Mount Sinai, where he was a chief resident. Since that time, he has served in numerous leadership roles for the department, including as a residency program director, simulation center co-director, and division chief for liver transplantation. He has authored nearly 100 publications, edited several textbooks, and received research and teaching awards for his work in the department. So on that note, live from New York City, sorry, I couldn't resist that for those of you who watch. Please join me in welcoming Dr. Sam DeMaria to this conversation. It is such a pleasure to have you here tonight. Let's make sure that everybody can see you. Welcome to the broadcast and to our sleep apnea series.
Hi, Carrie. Thanks for having me.
I have to begin here because I'm so curious about COVID and how it's affecting different parts of the world. For working at Mount Sinai, what is it like there with this Omicron variant, and how would it compare to the first early stages of the outbreak of COVID for you?
Well, I guess nothing really compares to that first wave that we had, where we were certainly, unfortunately, the epicenter for the United States at that point. New York City was definitely the hotbed. Since that time, we've progressively gotten better. This new variant is keeping us busy, but I think overall things are going well. Most of our issues now are sort of staffing. People are out testing positive, even if they're asymptomatic. Obviously, they don't come to work. And so we're just dealing with those kind of things, but we're out of an abundance of caution. We're, kind of just pacing ourselves back into normal. I think in the next few weeks, we'll start to see some improvement, and, vaccination has absolutely saved a lot of lives around here. So we're hopeful for the next few weeks.
One more question, and then I'll move into sleep apnea. But is this latest variant, Omicron, it seems like those people who are getting it, and I know a lot who have it right now, it's just not nearly as severe as the first outbreak. Is that a sign that perhaps the virus is weakening in strength, if I can use that, or perhaps you can provide some clarity in that particular area if that question is clear itself?
Yeah, from what we can tell from the best available data, and obviously things are changing and things are emerging as we speak, but it does appear to be more transmissible. So it's not surprising that more people are getting it. It does not seem to be nearly as dangerous. So it doesn't seem to be as severe in terms of hospitalization and mortality. But again, you also have a population that has immunity either through vaccination or prior infection. So, but that's kind of a good combination. So potentially a weaker variant with a hardier population hopefully means better outcomes for patients.
I love getting that good news, and
it's a flicker of good news, I think. So.
And so I'll take it and we'll run with it the way our world is today. Okay, let's move into into your work in connection to sleep apnea. So let's just begin by, I want to know this for anyone who isn't familiar with what an anesthesiologist is. Tell us who you are and what you do.
Sure. So, I think one of the double-edged swords of my specialty is nobody really knows what we do. So that's a good thing because they don't have a lot of people stepping on your toes, but you often have a lot of people who think they know what you do, but they don't necessarily understand what exactly it is you're up to. So I guess we can kind of get through some of the slides that I prepared just so everyone knows what I'm talking about today. We'll do a little intro to who we are. And I think that's important when you're talking about sleep apnea in the perioperative, the surgical period, because anesthesia is such a big part of making that happen. And I think a lot of patients don't consider what that means to the physician who's actually caring for them as sort of holistically as a full patient, while the surgeon is removing their gallbladder, let's say, right? So we'll talk a little bit about who we are, because I think that frames it nicely as to why this is important, and then we'll kind of get right into how that affects our patients. So
Okay.
I think if people think of what we do as a job, it's sort of we knock you out and then we wake you up. And I think that is part of the story. And so, it's important to consider what that actually means, though, right? So if you look at what an anesthesiologist was then in the Stone Ages, let's say in the 1980s,
Yeah.
right? Our job was really, and still is, to render patients unconscious. It sounds nicer than knock them out. And then later reanimate. I always like the term reanimation, which basically, we kind of put your brain, let your brain come back together so that you're back on earth with the among the conscious and the living. So that's put them to sleep and wake them up. And then there's this other part of it that I think a lot of people don't consider, which is we provide organ protection during surgery. Having surgery and having the anesthesia, the medications necessary to make an anesthetic soup, as it were, that's all very non-physiologic, non-normal stuff, right? Your normal reaction to having a scalpel cut into you is to run away screaming and crying. And yet here you are laying there motionless, with no pain inputs. And so what your body is actually going through, though, is still a very, very real stress, as if you are having surgery. And so a big part of what we do is really maintain normal organ function, whether that's your heart, your brain, your lungs, your kidneys. We're thinking about all of those other organs. Like I said, while your surgeon is operating on your finger, let's say, I'm really worried about your brain, your heart, and your lungs. And so, the marching orders for anesthesiologists were very simply protect them and then put them to sleep and wake them up. But our horizons have really broadened over the years. And if you look at this, this is from our top journal in anesthesiology. It's called Anesthesiology. So not a clever name, but this is our major scientific journal. And if you look at sort of our horizons in the 1840s, when anesthesia is first sort of experimented with at the Ether Dome in Boston, all we cared about was that little brown dot, which is what happens in the operating room. And if you kind of march out to today, we care about the preoperative interventions that we can do to optimize you for surgery. We care about your PACU, so that's the recovery area. And we care about hospital stay, but now we're starting to really think long-term outcomes. Anesthesiologists used to think their jobs ended in the operating room. And then we thought our jobs ended in the PACU. And now we really think that our jobs don't end until you're fully recovered and back to baseline, or at least some sort of improvement in your life. And we think about, how do we affect change in all of those phases? So I would say now the things that we're really interested in, and this will be very important when we talk about sleep apnea, are things like optimizing pre-surgical conditions. So if you have uncontrolled high blood pressure, let's say, if we can optimize that blood pressure before you come in for your surgery, that actually is very good for your outcomes. And then things like ensuring safe and enhanced recovery. Of course, we want you to be safe in an operating room. And we want enhanced recovery, which means not just did you survive the surgery, but do you thrive after the surgery? And that means some simple things like were you nauseous after your surgery, but it also means some very important things like did you get readmitted to the hospital after surgery? Did you need a prolonged length of stay after the surgery that was unexpected? And so that's what we mean when we say enhanced recovery. And then I guess, one thing that we always sort of have as a job description, and this is where, COVID sort of shined the light on us, is airway management. So
Okay.
we are the ones that breathe for you when you can no longer breathe for yourself because you've been rendered unconscious. And we are the ones that place breathing tubes and other sort of airway devices. So airway management is sort of the cornerstone of what we do. And it's sort of, at least in medicine, what we're known for, right? When they have a problem with an airway, we're the ones that they call to run to the floor and help patients.
So I guess that's where the interest, and of course, why you would care so much about sleep apnea. Is that the why behind that?
Yeah, so there's, many of these aspects are the why, but for sure, the place that most of us start in anesthesiology with sleep apnea patients is the way that you really start to respect this as a disease is the first time you encounter a difficult intubation because the patient has sleep apnea and their airway morphology is quite different than your average patient without sleep apnea. So I think if we take these things one by one, I can kind of talk about a little bit how this plays into the surgical journey of a patient. So on the next slide, you'll see, when we talk about rendering patients unconscious and reanimating them, all of the data that we have, nearly all of it, has pointed in the same direction, which is that the literature really supports that surgery and anesthesia pose very unique hazards for patients with sleep apnea. Everything that we tend to give patients, even simple sedatives for, let's say, like you're going for a colonoscopy or an endoscopy, and you might get what many people refer to as twilight. Those medications given to someone with sleep apnea can stop them from breathing completely when they're not really intended to do so. And so then you go from sort of a very simple monitored anesthesia care setting to a setting where you might have to really intervene very quickly to control the patient's airway, save their life as the case may be. And so they are sensitive to essentially every single anesthetic agent that we give. So that first part becomes fraught with peril right from the outset because patients with sleep apnea are just more sensitive to these drugs. So the next part of this, again, is that organ protection part, right, during surgery. And then if you look at the data for this, the best thing from what we can tell is that almost every single organ system that we care about, at least in anesthesiology, is affected by sleep apnea. And I'll focus really more heavily on the cardiovascular system and the pulmonary system. So, and sort of including with that the upper airway. But the comorbidities, meaning the diseases that sort of travel together, sleep apnea really travels with two major cardiovascular problems. And one is hypertension, so high blood pressure, and everything that comes along with that, which is coronary artery disease, increased risks for stroke, things like that. And it also travels along with pulmonary hypertension. So we're not going to get very technical here tonight because this is not the purpose of this this meeting. But your heart is essentially divided into two parts, right? The left side and the right side. The left side pumps blood to the entire body, and the right side is the side of the heart that pumps blood to the lungs for gas exchange. That's where the blood picks up oxygen from your lungs, takes it back to the left heart, and then the left heart pumps blood that's full of oxygen to all of your tissues. Well, in sleep apnea, the right heart, which is normally seeing a very low pressure because there's not a lot of organs it has to exchange with, actually starts to raise, and you get something called pulmonary hypertension. And pulmonary hypertension as a disease leading to unexpected death in the operating room or immediately afterwards is kind of the unsung hero, not heroes, I guess it's an unsung villain that most people don't know about and don't talk about. You'll see news stories quite often about an obese patient who probably had unobstructed or undiagnosed sleep apnea, who died unexpectedly after a simple procedure. And most often, 9 times out of 10, if you really looked at the records for what happened there. It's usually an acute pulmonary hypertensive crisis where the right heart failed completely and the patient succumbed to their disease. And that's all because they have sleep apnea. And so this is a really dangerous disorder because it causes all your other organ systems to incur this damage. And again, this creates a lot of problems in the operating room for us. The optimizing pre-surgical conditions part. Now, this would be, I think, wonderful if we had really sort of curative approaches to sleep apnea. The best we are sort of left with at this point is to work with our surgeons long enough before the day of surgery, which is an ideal world. And that's mostly just to identify patients who have sleep apnea. But there's not much that we can do in terms of treating them. On the next slide, I show a little bit about that. Even our societal guidelines basically just say patients should start CPAP or some other sort of oral appliance and lose some weight before surgery. But outside of that, there's not much we can do for them. And this is true. I mean, most of the danger in sleep apnea around surgery is just that you didn't identify it, and so you didn't have the high index of suspicion to monitor the patient more closely. And so it's a good recommendation, but it's not really incredibly helpful outside of just saying, find who has sleep apnea. It led to the development of a very important tool, which we use called the Stop Bang score, where we ask patients before their surgery a series of questions, and depending on their score, we can consider them a high risk for OSA or a low risk for OSA. But again, it doesn't change anything if I'm meeting a patient 5 minutes before the surgery. All it does is let me know you're probably a high risk for all of these other bad things to happen. And so we have to watch you maybe a little bit more closely in the operating room and afterwards as well. And so then
Dr.
Yeah.
Dr. DeMaria, I just have to jump in and ask, how long have you been using this Stop Bang screening tool?
So Stop Bang really was, I'd say, validated in the early 2000s. But in medicine, we sort of move, not at a glacial pace, but we're incredibly suspicious of anything new, even if it's a screening tool. And so things don't get adopted. The life cycle of most things being adopted is 10 years or so. And that kind of played out with Stop Bang. We saw a lot of this in the literature. And I would say by 2015, maybe a little bit earlier, we started to really regularly incorporate this into our preoperative history and physical. So really, we've been using this very, very well for about 5 or 10 years. But even when we use it in our preoperative clinic, it doesn't do much for us, because let's say you're having a surgery in 6 weeks from now, and they've sent you to a preoperative clinic where an anesthesiologist will see you. The anesthesiologist will do a Stop Bang score. They'll say you're at high risk for OSA. But in that ensuing 6 weeks, it's very unlikely that you'll even have the time to go get your sleep study, get your prescription for CPAP, tolerate the CPAP, adjust your settings. So we're kind of just left with, okay, we identified that someone has sleep apnea. We don't have a lot of other great options. And it's just kind of like, here's this guy, he's got sleep apnea, deal with it. That's kind of where we are.
Okay.
And so the last part, as I mentioned earlier, was this enhanced recovery and ensuring safety. Certainly, many of the societies that anesthesiologists belong to, like the Anesthesia Patient Safety Foundation, we even have a small sleep medicine sub-society within anesthesiology. We're paying attention to this as a safety issue. In one of our key sort of mid-tier lay press kind of things, there's a lot of talk about how we should treat this. Certainly, several years ago, there was an article about opioid-induced ventilatory impairment, meaning lots of patients will get pain medications, obviously, when they're coming for surgery. But patients who are at risk for ventilatory impairment, meaning stopping breathing, when they get those medications, we want to identify those patients so that they don't get into trouble and they don't die, obviously. And sleep apnea is really the greatest predictor of who will have opioid-induced ventilatory impairment, particularly if you have obesity and sleep apnea together. And if you look at the things that happen in these patients, they're not inconsequential things. This is death. This is brain damage. and even some minor injuries like needing higher oxygen levels. So as a result of some of these cases, the APSF started a death and near miss registry in 2014, as this became a real hotbed issue for anesthesiology, because we started to really look at closed claims. So that's closed lawsuits in anesthesiology.
Mhm.
And when you looked at where those claims happened, meaning did they happen in the operating room or did they happen after the surgery was finished, everyone thinks anesthesia is dangerous in the OR, but actually most patients have an untoward event after the case.
Right.
And most of those patients have that untoward event because it's either something to do with their heart, or it's they stop breathing. And if you have sleep apnea, both of those things are in the realm of possibility.
Dr. DeMaria, I just want to bring Dr. Sanjeev Jain, who has been a guest on our broadcast. He's joining us from Toronto, and a couple of comments he just made and said this is a topic that is often ignored and usually not talked about. So I'm very pleased to listen to such a great presentation tonight. And he goes on to say, from a prevention point of view, what would you think about having a screening and identifying patients with OSA at the pre-op clinic? And says this can be done using home sleep testing that has been validated using cardiopulmonary coupling. Your thoughts on that, Dr. DeMaria?
Yeah, I think if you want to indict the healthcare system in terms of how inefficient it is, pick sleep apnea as an example, and you will see all sorts of lacks of coordination. And I think that this is a great comment. We in a perfect world, the way that this would all roll out for every patient is, okay, you're going to have this surgery for, let's say you need a knee replacement, right? And you're going to meet with your anesthesiologist before that surgery happens, like several weeks before, if possible. That only happens in a small percentage of patients, particularly in the United States. Most patients will see their surgeon, have their surgery booked, and meet their anesthesiologist 10 minutes before the
Yeah.
surgery begins. And B, the problem is that many places, the referral base for how those patients do get to an anesthesia clinic to be seen are not really set up in such a way where there's like a clean way of sending them there. So I agree 100%. It would be wonderful if we could see the patients who are destined to have surgery with us. And then we could, we screen all of them, at least at Mount Sinai we do when we see them in our preoperative clinic. We screen them all, we do a stop bang, it goes into our note, everyone's aware. If we have the time, we do refer them to sleep medicine. But if we had the resources, we'd send them home with a sleep test. We'd be able to get them fitted for CPAP and start them on treatment early. But yes, the system is not built to be to be efficient, and we bang our heads into the wall all the time. So I guess this is a good point to just do a summary. With sleep apnea, which again, 1 in 12 people will suffer from sleep apnea. 90% of them are undiagnosed. And remember, in your lifetime, you will have between 5 and 10 surgeries. That's just the odds. That's how it is. You won't get off this planet without having some sort of surgery. And the average is really more like 5 to 10 procedures for most patients. So if you have sleep apnea, you've got 5 to 10 data points where everything has to go right, because it's potentially dangerous for you to undergo surgery. It doesn't mean you shouldn't get to surgery if you need it, but it does mean you should get it at a place that really appreciates and respects OSA as a disease, because increased likelihood of difficult airway, increased sensitivity to most anesthetic agents, a 2 to 3-fold risk profile for cardiopulmonary complications. Postoperative opioid use becomes a real problem because of ventilatory impairment. Obesity and aging, we're all getting older, that's for sure, and many of us are gaining weight. So those things are additive to OSA and make it even more dangerous. And we're stuck with existing guidelines, which offer us very little. Most of the goals are just to identify and watch the patients. But still, 70% of OSA malpractice claims are the classic found dead in bed patient in either the PACU or in the hospital bed, or even sometimes at home. And so that's sort of why this is near and dear to the anesthesiologist's heart. So again, remember, patients are having surgery. Anesthesiologists in that way are frontline providers. And disease management is really the main barrier at this point. Now, there is a push, and we can talk about this a little bit, to do more and more surgery in ambulatory surgery centers. They tend to be a little bit nicer for the patients. They're kind of like a spa with some operating rooms attached oftentimes.
That would be in America, right?
Yeah,
Just in the
yeah,
US, not
exactly.
in Canada.
But yeah, probably. But we love ASCs in America. That's ambulatory surgery centers. We're
Okay.
doing more and more. We're pushing the envelope. First, you could only do plastic surgery and ASCs, like mole removals. Then you could only do minor lumps and bumps, as we call them in anesthesia and surgery. And now it's like everything from one level spine laminectomies to knee replacements, and we're going to keep pushing the envelope. And what we never did was we never did sick patients in the ASCs years ago. It was only young and healthy people who didn't want to go into the hospital, who same day surgery, they kind of run in and leave. But now we're doing older, sicker, because we've got a lot more old and sick patients, and we're doing them in ASCs. And it's a lot of lay press where you see it over and over. Beloved principal dies in an ASC while getting a simple procedure, and it's usually an OSA related death.
Yeah. Oh, Dr. DeMaria, your presentation was so insightful. I learned so much from talking to you. More than anything, it gives me hope in this conversation that perhaps we're taking the right steps towards bridging the gap and talking more about OSA. And I'm curious to hear Dr. Haight's thoughts on that as well. But with your stop bang approach to everything, it's like I said, encouraging to know that these steps are being taken, and that sleep apnea isn't some like up in the sky, pie in the sky idea. It's real and it affects us. And the more we talk about it, the more awareness we can bring to it, and hopefully the more collaboration between medicine and dentistry. So I appreciate your time. I'm going to allow you to catch your breath for a bit in the virtual green room, and we're going to move ahead with our presentation, but I will bring you back in about 20 minutes time to close off our conversation. Thank you so much. I really appreciate your perspective. Okay, on that note, everybody, we're going to move along, and it's now my pleasure to welcome Dr. DeMaria Jr to the conversation. As I've mentioned many times before, she is the driving force behind these broadcasts, so determined and passionate about fostering more collaboration between doctors and dentists and diagnosing sleep apnea, ultimately in saving lives. And Dr. Jr has spent the last 25 years working in general and craniofacial dentistry and lecturing worldwide for 10 years to all sorts of experts, including dentists, orthodontists, and medical experts on her published research and findings. Dr. Jr has successfully reversed sleep apnea, and she is going to talk more about that. And she's always on a relentless mission to get dentists and doctors to work together on the diagnosis and treatment of sleep apnea. So on that note, I welcome her back and into the broadcast. Dr. Jr, it is so nice to see you.
Thank you, Carrie. It's great to see you. And Dr. DeMaria, that was a fantastic presentation. Thank you so much for just clarifying what a person goes through when they have a surgery, and that every single person is going to have some surgeries. So this is going to be an every man for himself, get yourself healthy talk.
Yes.
So what are your...
I want to bring this right in, Dr. Jr. Dr. Jane says dentists use anesthesia in their practice, often sedation for oral surgery, and this is usually done out of the hospital.
Yes, and as many people know, I was a nurse for 10 years, and I did work in ICU. And as a dentist, I didn't do the sedation, maybe because I saw the flip side of it. But there's a need for it, and they will get anesthesiologists in there to do it. But I think dentists can help in a big, big way with this problem that Dr. DeMaria is bringing up today.
And you want to talk more about that interdisciplinary collaboration. What does that mean for patients overall?
Well, it's not just like patient by patient. I think medical doctors and dentists need to understand and how they can help each other. And there's a big way that dentists can help with interdisciplinary collaboration beyond just the individual patient, like referring a patient. They tend to see all these healthy patients. They come get their teeth cleaned every 6 months. There's an opportunity for dentists to screen patients. And even like Dr. Sanjeev Jain said there, dentists can test them with this new technology, this cardiopulmonary coupling in a home sleep study in a calm, easy environment. And I think if hygienists had the opportunity to, screen the patients and the patients could go home with one of these studies, potentially that person could find they might have sleep apnea and actually do something about it, just for their own health, not just preparing for surgeries. So that's one way. Another way is, I'll frequently get patients from other dentists and medical doctors that have sleep apnea, and dentists can help medical doctors treat sleep apnea. And there's probably about 200 different dental devices that hold the jaw forward. Now there's like a way to change the craniofacial anatomy and prevent the development of abnormal craniofacial anatomy, and really prevent a whole lot of this stuff that medical doctors need to know. Dentists can do this. So what a dentist can do in my position, or there's many dentists who like to treat craniofacial pain and temporomandibular disorders, and they're recognizing close link between sleep apnea and pain, and they're starting to do sleep dentistry. And so what they can do is make a letter for the medical doctor that outlines, the history and their findings, what they see in the patient, and what that dental diagnosis is, to help medical doctors realize that we can do these things to really assist with the treatment of their patients that have sleep apnea. And there's some patients that we actually reverse sleep apnea in, and I'll show you how it works. But these are the main things: the screening, making a letter to collaborate, and assisting in the treatment. And then finally, it's very important for dentists who are doing this, these are the leaders in dentistry, to document your findings. Like, do before and after sleep studies when you're making the jaw big enough to fit the teeth in. You'll be stunned what you're doing to these people's measurements and their metrics, because medical doctors need those metrics. And, if it works, they're going to grab onto it. I think we can really help. And so that's what I love about having this episode, and having such a great anesthesiologist like Dr. DeMaria here.
Oh gosh.
Talking.
Dr. Height, you gave us so many examples of how dentists can help, and I know that you have patients to go with those examples. So walk us through a couple of those, because that really paints the whole picture.
Okay, well, here's a patient who just had headaches, and so she came to my clinic because as a dentist, I was reversing people's headaches just by developing their jaws so their teeth fit. So she didn't come because she had crooked teeth, but you can see a big difference in her anatomy there. And we grew the bone volume there of the upper jaw, the maxilla, which contains the nasal airway, by 1.8 cubic centimeters. And these are in adults. And then the nasal airway, the physical nasal airway, grows as well. So that's one example. And, if the doctors like stats, basically I like to do headache impact tests on the patients before and after using the dental treatment. I use a biomimetic oral appliance therapy. And this was a snapshot in time a few years ago, and now I have 100 data points there. There's only so many patients there, but there's more and more dentists learning how to do this and actually doing it. And I'll show you exactly what it is we're doing. If you move on to the next one, we're correcting these craniofacial developmental deficiencies by growing the actual bone volume of the maxilla. And this, was taught in dental school when I went to school back in the Boer War, that the maxilla could not be grown in adults. But you can grow that maxilla, and the hole in the maxilla, the nasal airway, gets bigger too. So then what happens, there's enough room for the teeth to fit, and the bottom jaw now can come forward and open up the airway in the neck. So that's what made dentists start doing sleep studies, before and after treatment, so that we could capture this data. And then now we want to tell our medical colleagues about it. So that was just for pain. So her pain went away because her sleep scores went down. This is a patient who actually had sleep apnea, and very, very severe sleep apnea. She stopped breathing 118 times an hour, and 30 is severe. So it's like a 4 times severe sleep apnea. So the way I think of it as a dentist is that the teeth and the jaws are like a garage and the tongue is like a car. Mm-hmm. And on the left, when she had the disease, her bottom jaw is so far back, she has a garage for a smart car, and her top jaw and teeth overlap her bottom, teeth by 50 or 60% there. We call that an overbite. And so she's got a garage with a 6-foot ceiling. So after the treatment, where we actually developed the upper jaw, her bottom jaw was able to come forward. So the tongue is out of her airway. Now she's got a garage for a stretch limo, and, a 10-foot ceiling in the garage. And if you look at her from the front, you'll see that the 1-car garage is now a 2-car garage because the arch width has expanded. So that maxilla grows 3D. And, cosmetically, there's an improvement in symmetry. There's room for teeth. Teeth don't need to be extracted. These are things now that dentists are really, really excited about. But the idea that we're actually reversing, quadruple severe sleep apnea is really, really exciting. That in and of itself is huge. How long does it last? And all these things are other questions. But the anatomy of the teeth and the way the jaw works and the bio, feedback mechanisms and things, the teeth can then be lined up by orthodontic specialists in, with the lower jaw in this rest position, this physiologic rest position. There's no reason why that shouldn't last. So that's all going on right now.
So when you're doing this, so Dr. Height, why is the pain going away?
I think, we can only guess. Pain is closely related to sleep apnea, because when there's less oxygen going to the brain, people get headaches. Also, when the bottom jaw is too far back, there's pressure in the temporomandibular joints, and there's congestion there. And so people will experience pain in the face and headaches, and then they'll posture their head forward. They'll have neck pain, and they'll have to compensate down in the lower back. They'll have lower back pain. It infects the entire body. So those people that are working on temporomandibular joints and craniofacial pain, kind of more complex dental patients, really understand this. And they're all treating and discovering sleep as part of their practice. But the one thing that's really exciting is the knowledge, or the null hypothesis, that the maxilla cannot be grown in adults, because it can. We've done it. Mm-hmm. There it is right there. And you can do it in men, women, kids. I'll show you the next one real quick. This fellow just had craniofacial pain. This was before I even started measuring for sleep apnea, but we started taking photos, and you can even see the functional space, of the upper airway developing and improving in symmetry. Mm-hmm. And then to move on, this is where it's really exciting. Kids, if they don't get oxygen, they don't grow as well. And the minute you give them the ability, even just a little bit, change their anatomy and their maxilla, they grow. And this boy, in 8 months treatment, even the size of his head grew, his brain, his upper jaw came forward. That angle there of the chin and the neck, that's the thyromandibular angle, is obtuse there on the left, and now it's more normal on the right. And all we did was work on the upper jaw. And so, like, if we take a look of the upper jaw from in the next photo, you can see, he he too has a change in the upper jaw, even the way he postures his lips and the nasal airway. And to move on, because dentists love looking at teeth, you can see that the impact of this treatment on the teeth. So we put some blue risers. A kid named that for me. We call them blue risers. To give him a bigger ceiling in his garage, and then the jaw is just developing normally. And in dentistry, we're just really creating the space, and the tongue is doing the work. So things like tongue ties and things are something that need to be recognized and learned and dealt with right at infancy. And you can have a side view of that too. I've done over 4,000 infant frenectomies so that babies could breastfeed. And we're seeing way less of this in that group of people who have free tongue that can develop the maxilla than, those kids that have tongue ties. And it affects them, many of these kids are thought to have ADHD and things like that. And the whole sleep apnea thing is completely missed. But now with cardiopulmonary coupling and simpler home sleep tests and dental clinics that are recognizing this and screening people and kids and recognizing these craniofacial deformities, can send the kids home with a sleep study. They can pass around the whole family, find it, and prevent everything from developing. So this is the impact in my clinic, and this is a couple of years old too. The dark blue area is pre-treatment. That's how many people I treated that had severe sleep apnea. The less dark blue is moderate sleep apnea, and the lighter blue is mild sleep apnea. So that entire group of patients had sleep apnea. And then on the right, after treatment or during treatment, it was a snapshot in time. All those severes shrunk way down and poured into the moderates, and the moderates poured into the milds. But look at all the complete reversals. So this is super, super exciting for dentistry, and in the context of having a high quality life and health. This isn't just for sick people and people who need surgery. This is for healthy people. And anybody can look in the mirror and see they have crooked teeth and a small jaw. So diagnose yourself, go to your dentist, and we're going to collaborate with medicine. And I'm really excited about that and where this is going.
Well, your results really are stunning. And when you see those pictures, what's so shocking is just that it's the same person, especially the first case and then the little boy that you talked about. But again, wrapping up the conversation, you said is collaboration. So with that, I know where you want to go. And so I'm going to add Dr. DeMaria back to this conversation because you want to begin by talking about collaboration. And I'm going to ask this question, and I ask it from a layperson's point of view. Dr. DeMaria, is like, is this for real? Like, be honest, a collaboration between doctors and dentists. Sometimes the two just don't want to talk to each other. Is there a respect issue, or is there a hierarchy issue? Like, why is there such a disconnect?
Well, I think it's within medicine, you see lots of cultural differences between specialties. You definitely see the same thing between medicine and dentistry. I don't think there's any ill will or there's any sort of negative sort of relationship. But I would say the following: most physicians, most doctors, the extent of their knowledge of sleep apnea kind of ends with CPAP. And because in the course of their life, in their daily professional life, they say, oh, you have sleep apnea, you go get CPAP. And I think that's because, well, CPAP is the gold standard. It is evidence-based. It works great. It improves patients' lives and it improves their health. But we've seen over the past couple of years, lots of different modalities come. And so there are options now. And I think, we're finally starting to see with devices like Inspire, which is a surgical approach to correcting sleep apnea, really widespread acceptance. And again, really 10, 15, 20 years ago, nobody's referring a sleep apnea patient to a surgeon unless there's some sort of crazy amount of craniofacial deformity. Now we're just seeing patients with more run-of-the-mill redundant soft tissue getting surgical intervention because they can't tolerate CPAP. The dental approaches have been fairly limited. Most of what you see in dental practice for sleep apnea has been limited to the sort of, what we would call like just the mouth guard approach, like the mandibular advancement devices that people have to wear when they're sleeping, and then they sort of have to use for the rest of their lives. And they're just of variable effectiveness, and they're not always, a real long-term solution. So, what Dr. Height is talking about here is kind of like the best of many worlds, right? You've got potentially a solution that sticks, sort of like the surgical solutions do, where you're not, wearing a CPAP mask every single evening, and it's a non-surgical solution like CPAP is. So, I think it's fascinating stuff. It's very exciting, and I guess how do you knock down that wall between doctors and dentists? I think a lot of it is, it's evidence, right? Physicians crave evidence. We want to see it in our journals. We want to see what the data look like, and we want to see it on large scale. And then we want to know it's safe, right? So we want to see, a real vetting, whether that's by the FDA or whatever the local bodies might be. And then, slowly but surely those things trickle into practice, and before you know it, you blink and 10 years go by, and maybe it becomes the standard, or maybe it becomes the second standard for those who don't want the other standard. And what we do need is options, because you can't just have one choice for everybody. You can't just always be CPAP. And so it's fascinating to hear a lot about Dr. Height and other dentists' work.
All right. What are your thoughts on that, Dr. Height? You're nodding a lot in agreement.
Yeah, it's going to take time, but everything's in if there's such a huge benefit with such a low risk, like this is not scary or threatening. You can put it in your mouth. You kind of talk with it.
You can't do a podcast with it, but you can
podcast. But I mean, the side effects are excessive salivation. You can't talk with it in the mouth, and you might get gaps. But if you have crowded teeth, you almost kind of want gaps. So if patients knew about it, and they knew about how risky and bad it is to have sleep apnea, just like people are learning about taking vitamins or doing all these other things, exercising for their health, I think they'd be pretty excited to know how a dentist can help them even be healthy for their future surgery. And I feel like the collaboration part is going to be the data. And I agree. I think this has to be evidence-based, and we need the data, and we've got to get dentists giving that data. And that's why I'm really, really excited that we're going to have a presentation at the World Sleep Society in Rome in March, because that's just the beginning. There'll be a lot of top sleep doctors there curious, or they'll hear about this for the first time. So when that happens, when people go to a conference and then they watch a presentation with such few side effects and such a big opportunity for prevention, is it still going to take 10 years? Or is, I'm just kind of like, where do we go from here?
That is a great question. Do you want to pick, where do we go from here, Dr. DeMaria? Do we have to just be patient?
Well, I mean, obviously, if the pandemic taught us anything, it's never predict the future, right? So, I don't know. I think if I'm just obviously talking about rate of adoption. At least the established sort of intervals in medicine tend to look like 10-year cycles, even for simple things. But yeah, I mean, to Dr. Height's point, every now and then things do come along that are such no-brainers, as it were, right? I mean, we all want things that have very, very low side effects that ensure very, very high compliance. Compliance is a big problem. That's really the kind of the linchpin with CPAP. That's why it's always an issue for patients.
I wanted to bring in this comment as you said that is Dr. Jane from Toronto is saying efficacy for CPAP is proven, but effectiveness includes compliance and adherence of a treatment. And oral appliance compliance rate is generally higher, so possibly more effective.
Yeah, I mean,
Like,
it
what would
really is a no-brainer. I think that it's if you made your sleep apnea treatments into three sort of buckets, right? The ventilatory CPAP intervention, the surgical correction, and then the dental correction. The dental correction is that the Goldilocks sort of phase for this thing, right? Where the compliance is high, because once you've had your Inspire surgery, you've had your Inspire surgery, so you're now compliant. But the effectiveness is potentially as good as a CPAP machine. Well, yeah, I mean, I think that's a no-brainer for most patients. So then awareness becomes a bigger issue. And so I think before you can really affect any meaningful change, patients have to know it exists.
So and with compliance, as someone who's been practicing a long time, I find with this device, the idea of temporary compliance makes a patient much more compliant if they know there's a goal and they try to get to their maximum medical improvement. And kids are really compliant with this. I don't know why. I think they actually feel better. They're getting more oxygen. They just feel better. That's my guess. But if a person, with this technique, with boat therapy, it would be temporary compliance, and then finishing a person's teeth or stability with either braces or some people can get away without it, but I think most people need their teeth lined up when the jaws have changed. But I feel like this should be going way faster, but I'm not that patient.
Well, I guess tonight in a broadcast like this and in the gathering in Rome, they're all steps in the right direction. And the more we talk about it, the more awareness we raise, and the more the two of you and everybody else who's participated in these broadcasts are shining the light on the importance of collaboration and how it ultimately can save lives. We could go on for hours, you two, but I like such a brilliant and insightful conversation and presentation from both of you. I appreciate the time that you took, Dr. DeMaria. I wish you all the best in New York, and hopefully that pandemic goes down, 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 down. So I wish you health and wellness to you and your family. Thank you so much for joining us on tonight's broadcast. We really appreciated your time and your perspective.
Thanks for having me. It was a good time.
Thanks so much.
And to you, Dr. Haidt, the driving force behind these broadcasts, we just continue on the path, and you continue on that path of never giving up. And you've been relentless in creating more and more collaboration between, medical experts in all walks of life and dentists. And I'm so happy to hear that you will be presenting in Rome and getting your message out there, because it needs to be heard.
So thank you so much, Carrie. What the really neat thing is that it probably won't be me presenting, but it'll be a medical doctor, which, when we get to interdisciplinary collaboration, that's the sort of the peak of it, is to have your evidence presented by a medical doctor at a medical conference is humbling, and I'm really, really excited for it. And I hope that everyone watching this, knows it's going to be sitting on YouTube and you can spread it around. This is a great message that's easy to send to the medical doctors, you work with, or the dentists you work with, so that they can get with the right people and really learn how to do this.
A few closing comments here from just want to show you from Delta Sleep. They say Rashida from Delta Sleep. We have had a handful of non-compliant CPAP users, that are open to using the DNA. So that's always good to hear. From Dr. Jane, efficacy for CPAP, but we already talked about that comment. And then this one, just I do believe, if I'm not mistaken, this is Ukrainian. And this person was thanking us for a great presentation, but I am not able to read the first and last name. So, but I do wanted to draw attention to it and say thank you very much. So to all of you joining us from around the globe tonight and participating in this conversation, we certainly appreciate your time and your perspective. Once again, to Dr. DeMaria and to Dr. Height, thank you both so much for taking your time to explain your work in this area and the importance of it. And as I mentioned at the very beginning of this broadcast, if you missed this whole presentation, you want to watch it again or want to share it with anyone you know, all you have to do is go to the website, thescienceofsleepapnea.com. On behalf of Dr. Height and myself, thank you so much for joining us. It's been an absolute pleasure to serve as your host. And do go and visit that website, share it with everybody that you know could benefit from it, because ultimately, as Dr. Height says so many times, this is about saving lives. Thanks for joining us, everybody. We appreciate your time.
Bye-bye.